A warm welcome to all of you to the Cervilon Masterclass Series Session 3. Please join me in welcoming Dr. T.S. Jain, sir. Welcome, sir.
Thank you. Thank you, Dr. Adithyan, for giving this opportunity to present my clinical experience and the expertise in the cervical spine area. Let's start here. Before starting our presentation, a few clinical scenarios I was presenting. At the end of this presentation, we'll be able to answer these scenarios. The first one is a middle-aged man present with chronic neck pain aggravates on activity. That means working on computer, long hours in the office, watching TV or mobile with radiation to the trapezius muscles, scapula, or over the shoulder. A middle-aged man present with chronic neck pain aggravates on activity with radiation on the trapezius, scapula, or over the shoulder. A 45-year-old male presents with neck pain radiating the outer aspect of the shoulder, arm, forearm, and hand with the Spurling test positive. We will discuss the Spurling test later. Yeah, what is the diagnosis that we'll be able to answer at the end of this session? A 45-year-old male presents with neck pain radiating the outer aspect of the shoulder, arm, forearm, and with the Spurling test positive. A young girl presents with paresthesia on the ulnar side of the hand and forearm, increased with local sweating and absent or diminished radial pulse on Edson test. What is the diagnosis? An older man present with a chronic history of cervical spondylitis associated with progressive gait disturbance, clumsiness in the hand, and exaggerated deep tendon reflexes in both upper and lower limbs. See, we'll be answered to these scenarios at the end of this section, I'm sure. So the cervical problems can be divided into two: traumatic conditions and non-traumatic conditions of the cervical spine. Traumatic conditions and non-traumatic conditions affecting the cervical spine. A brief account about the cervical traumatic conditions. The initial approach of this cervical traumatic conditions always assumes cervical spine injury in trauma. Always assume a cervical spine injury in trauma. So cautious while doing the clinical examination. Apply rigid cervical collar or immobilization or gentle touch feel while we are doing the cervical spine examination. The primary survey, of course, we have to give ABCD. The airway we have to check airway patency without neck movement. That is very important. Check airway patency without neck movement. The airway compromise at the higher cervical injury, say at the level of C3 to C5. Airway compromise, we can observe the injury at the level of C3 to C5. And breathing, observe the chest movement. First, you have to do the inspection. Look the chest movement findings, the diaphragmatic breathing is present or not possible. High cervical cord injury, we can observe the diaphragmatic breathing. We see. Then we have to check about the circulation. We have to check the pulse, BP. The findings may be in cervical spine injury, hypotension plus bradycardia. We have to make a clinical diagnosis and neurogenic shock. The hypotension with bradycardia. Observe the circulation also. Then we have to look for the disability. Any neurological deficit is there. Ask the patient to move all the upper limbs and lower limbs, and we have to check for the consciousness also. The secondary survey, if it is okay after having this ABCD survey, the secondary survey detailed cervical spine examination we have to look. In Acharyas, we very clearly said that the examination is Darshana Sparshana Prashnegi. First, you have to look any deformity, whether he can move his upper limbs or lower limbs. So, in inspection, what are the things we have to keep in mind? Is there any neck deformity? We have to, while seeing itself, we can observe any deformity at the level of the cervical spine. The swelling, bruising, abnormal posture, that torticollis we can see. So also the open wounds also. These things we have to keep while inspecting the patient. the neck deformity is there, swelling, whether the swelling is there or bowing is there or abnormal posture is there or any open wound is there or not. Findings. If we find any step deformity, definitely we can make a conclusion that there is a displacement of the vertebrae, cervical vertebrae, a step deformity we ought to look for. So also the guarded posture, if muscle spasm is there, the guarded posture we can observe in patient. Then we have to darshana, prashana, sparshana. We have to do this parshana or palpation. The method gently palpate the spinous process. Very gentle approach we have to do. Gently palpate the spinous process. What are the findings we have to get? We have to keep in mind the midline tenderness is there or not. While examining, we have to flow our thumb on the posterior aspect of the neck, and we have to observe any midline tenderness that shows, if there is any midline tenderness, that shows the strong indication of fracture. Midline tenderness in traumatic cases. So also a step of deformity. Is there any step deformity? We have to assume that there is a dislocation or fracture like that. So also we have to observe the paraspinal muscle spasm is there or not. If there is that much of paraspinal spasm, we can think that a soft tissue injury is there. So while doing the palpation, very gentle approach we have to do, and the findings we have to observe is there any midline tenderness is there or not, any step deformity is there, or paraspinal muscle spasm is there. In midline tenderness, we can assume that a strong indicator of fracture. A step deformity also fracture dislocation. A paraspinal mass spasm usually we observe in soft tissue injuries. So also next, if that much of, after doing the inspection and palpation, if there is not that much of problem or the fracture or dislocation or neurological deficit, we have to look for the range of motion of the cervical spine. Do not perform if instability is suspected. If any fracture or dislocation or step deformity is there, do not move the cervical spine. The findings we have to observe is painful restriction or spasm we can observe in paraspinal ligament injury or fracture, painful restriction we can observe. So if complete instability, there is severe injury we can assume. So the neurological examination, what we have to do is, if the C5 nerve root is affected, shoulder abduction will be difficult. Shoulder abduction will be difficult. If the C6 nerve root is affected, elbow flexion will be weakness. C6, elbow flexion will be weakness, and in C7, elbow extension will be weakness, and C8, finger flexion will be difficult. And the T1, finger abduction will be difficult. Loss of fine movement. Loss of fine movement also affected. So if the C5 nerve root is affected, the patient can't abduct the shoulder joint. And if the C6 nerve root is affected, elbow flexion will be weakness or difficult. And C7 nerve root is affected, elbow extension is weakness or absent, difficult. And if the C8 nerve root is affected, finger flexion will be difficult. Grip weakness we can observe. If C8 nerve root is affected, grip strength will be weak. And a T1 nerve root is affected, finger abduction will be difficult. These are the neurological findings we can observe in the patient. If the C5 nerve root, C6, C7, C8, and T1. And then we have to look for is there any sensory deficit? Sensory examination, practically we are doing pain, temperature, and touch. Pain, temperature, and touch. Is loss of sensation, nerve root or cord involvement we can assume, and sensory level, at what level the injury is also we can assume. We can make a clinical diagnosis. Then reflexes, we have to do the biceps reflex. If C5 and C6 level, that means the C5, C6, the C6 nerve root is affected, the biceps reflex will be diminished. If C6, C7, that means the C7 nerve root is affected, that the triceps reflex will be diminished. So also if the upper motor neuron later onset, initially if there is an injury, patient will be on spinal shock. At that time we can't get any spinal reflexes. We will not get. After the recovery of the spinal shock, we will get the reflexes and all these things. On the later onset of injuries, the upper motor neurons are affected. Babinski sign will be positive. That means the dorsiflexion of the big toe of the lower. So also Hoffman sign suggests a cervical myelopathy. It's a later onset myelopathy. That means flickering the middle finger, the index and the thumb will automatically move. That is the Hoffman sign. Usually we are seeing in cervical myelopathy. The special neurological patterns are the spinal injury, complete cord injury and incomplete cord injury. Injuries can be divided into two, column injury and cord injury. Column injury means the injury to the vertebrae, articular facets, or the lamina, or the bony structures, and the intervertebral disc. That is the column lesion. Cord lesion means injury to the spinal cord. So injuries can be divided into two, column lesion and cord lesion. Column lesion means injury to the vertebrae and the bony structures and the intervertebral disc. Cord lesion means injury to the spinal cord. So if the injury to the spinal cord, it can be divided into two, broadly divided into two, complete cord injury. If the complete cord injury is there, motor plus sensory loss below that injury level. Motor plus sensory loss below that level. If it is an incomplete injury, it can be divided into three: central cord syndrome, anterior cord syndrome, and Brown-Sequard syndrome. So injury to the central cord, I shall show the picture here. Central cord injury, if the injury is the central cord of the spinal cord, upper limb weakness greater than the lower limbs. If the central cord is an incomplete injury to the spinal cord, the upper limb weakness is more rather compared to the lower limb weakness. So in central cord injury, upper limb weakness is more compared to the lower limb. If it is an anterior cord syndrome, yes, here you can see the anterior cord syndrome. Loss of motor plus both motor plus sensory sensations like pain and temperature will be altered. The anterior cord syndrome, loss of motor plus pain and temperature sensation will be diminished, plus the preserved proprioception. In anterior cord injury, the proprioception sensation is preserved while the motor plus pain and temperature sensation is diminished. So also in the Brown-Sequard syndrome, ipsilateral motor loss plus centrolateral pain temperature loss, contralateral pain temperature loss. So in this cord injury can be divided into two, complete cord injury and incomplete cord injury. In complete cord injury, total motor plus sensory loss below the level of the injury. In incomplete injuries can be divided into three: central cord syndrome, anterior cord syndrome, and Brown-Sequard syndrome. In central cord syndrome, upper limb weakness is more compared to the lower limb. And the anterior cord syndrome, loss of motor sensation, motor power plus pain and temperature sensation will lost and preserved the proprioception sensation. In Brown-Sequard syndrome, ipsilateral motor loss and contralateral pain temperature sensation. So autonomic functions also you have to observe findings. If there is any urinary retention, special spinal cord, maybe the spinal cord involvement is there. So also loss of anal tone also we have to observe the anal tone also. Severe cord injury, anal tone will be loose. So the red flag clinical findings of injuries, quadriplegia, respiratory distress, loss of bowel or bladder control, severe midline tenderness, and progressive neurological deficit. So in short, the midline tenderness, we have to think about the fracture. If there is step deformity, we have to think about the fracture dislocation. Neurodeficit plus pain, stable injury. No neurodeficit plus pain, that means it's a very well we can manage. That is a stable injury. Neurodeficit present, that is a cord compression is there, and hypotension plus bradycardia means the patient is on the neurogenic shock. So if there is pain, that means aggravation of Vata dosha. If there is stiffness, the aggravation of the Kapha dosha is there, and the loss of function, that means Teshtagani, again the Vata involvement is there, the numbness is there, there is vitiation. So these cases also we can manage very carefully. Very carefully, we have to immobilize the cervical spine with a immobilizer or the bandage we can do. So also internal neuroprotective medicines first we have to see. The line of the treatment is first we have to heal the neurogenic cord injury and the column injury. If the permanent damage is there, nerve injury can be divided into 3 grades: neuropraxia, axonotmesis, and neurotomesis. Neuropraxia means only a contusion to the nerves. Contusion to the nerves that very well require in our treatment. Neuroprotective internal medicines like Shundi Beladi, Shirapaka. So also the Rasnaranda Kasha, Laksha Gulgul, all these things we can give internally. Neuropraxia very well will recover. If it is an axonotomesis, means injury to the level of the axon, that also recover. It will take much time to get healed. At that time, the patient experience burning type of pain. Axonotomesis and neurotomesis means complete transection of the spinal cord. It is very difficult to get recovery. So injuries can be, nerve injury can be divided into 3 grades. That means neuropraxia, axonotomesis, and neurotomesis. Neuropraxia means a transient neurological deficit will be there. That means contusion to the nerves. At that time, the root inflammations will be there. So also the spinal cord inflammation will be there. After subsiding the inflammation, and so also the internal medicines and the rest and the protection to that injured area, it will recover. Neuropraxia. Axonotomesis means injury to the axon level, that also will regenerate. So also neurotomesis means complete transection of the spinal cord, where the recovery rate is being very, very, very poor. So first we have discussed the traumatic, briefly we have discussed the traumatic condition of the spinal cord and how we will approach the patient while a patient comes before you. Very carefully we have to examine and manage that cases. And the non-traumatic conditions also divided. The next step is, next session is the non-traumatic conditions of the cervical spine. What are the pathological conditions affecting at the level of the cervical spine? Non-traumatic conditions of the cervical spine. Non-traumatic conditions of the cervical spine is degenerative, inflammatory, and infective. Non-traumatic conditions of the cervical spine are degenerative, inflammatory, infective, neoplastic, congenital or development, and others. So degenerative conditions usually but at the level of the cervical level is cervical spondylosis, cervical disc prolapse. And inflammatory conditions usually we are met with this rheumatoid arthritis involving the cervical spine and ankylosing spondylitis, and the infective conditions like tuberculosis of spine, discitis, and the neoplastic conditions usually we see at the level of the cervical spine is primarily the tumors and metastasis, the congenital or developmental anomalies like cervical canal stenosis, congenital cervical canal stenosis, and the atlantoaxial disability. Others usually we met is cervical myelopathy and posterior neck pain. Usually we met in IT professionals. So the normal non-traumatic conditions also divided into two: column lesions and cord lesions. Column lesion means the disease is affecting at the level of the bone, intervertebral disc, articular faces, like that. Column lesions. Cord lesions means the disease is affecting the spinal cord. So the common non-traumatic cervical spine conditions are degenerative, inflammatory, infective, neoplastic, congenital or developmental, and others, mainly cervical myelopathy and postural neck pain. So while a patient comes before you in the OP, first we have to scientifically assess the patient condition. At first, we have to take the history. Acharya very well said how you have to examine a patient. Darshana. While seeing the patient itself, we can make some assessment. Darshana. Sparshana. Sparshana means palpation. Palpation. Touching the patient, and we are doing some test, and we are making a clinical diagnosis. Darshana, Sparshana, and Prashna. History taking. History taking is very, very, very important in any case. For a practitioner, first you have to hear what the patient is saying. You have to open the ear and hear what the patient is saying. So if you spend a little more time to hear the history, while the patient itself will give a diagnosis. That is the importance of the history. While taking the history, first you have to think about the pain of the cervical spine. So if the patient says about the pain at the cervical spine, we have to look for the site of pain at neck, whether it is radiating to the arm. We have to think about from where it is radiating, that you have to look for. Usually the pain will be at the level of the cervical spine and radiating to the upper limb. Usually the patient says on the lateral aspect of the upper arm and the medial aspect of the upper arm, like that. And sometimes the patient says the pain radiating the inferior angle of the scapula and the trapezius, and like that muscle. So site of the pain is very important. So also the radiation of the pain, and we have to ask the patient whether it is radiating on the lateral aspect or medial aspect or the inferior angle of scapula, like that. We have to ask. So whether the nature of the pain also we have to look for, whether it is a dull pain or sharp pain or a burning pain. Whether the pain is a dull pain, sharp pain, or a burning pain. So also duration, whether it is an acute onset or a chronic onset of this pain. Whether the pain is on acute onset or a gradual onset of the pain, that we have to look. So the importance of pain history is very important. First, you have to think about the pain. So ask the patient from where it is originating, and is it radiating the upper limb, whether it is medially or laterally or inferior angle of scapula or the back of the occipital, like that. So also the nature of the pain, whether it is dull, sharp, or burning pain, like that. So also the duration of the pain, whether it is a sudden onset of the pain or it is a gradual onset of the pain. That is the importance of the history while taking the cervical spine examination. So also the radiation pain, radiculopathy, whether the pain is radiating to only one upper limb or both. That also we have to think whether the radiating pain is to the only one arm or is it radiating the both upper limbs, that we have to look for. So also the aggravating factors also we have to ask. Whether the pain is aggravating while the neck movement, so or prolonged sitting or the night pain. If the pain is aggravating at night, we have to think about the tumor or infection. So also we have to think about the relieving factors of the pain, whether the rest reduces the pain or while applying the cervical collar that reduces the pain, that also we have to think that about the history. By taking the history, first we have to give importance to the pain. So the site of the pain, the radiation of the pain, and the aggravation of the pain. So also the relieving factors of the pain, that also we have to think for. After taking the history, we have to do the palpation or neurological examination also. We have to think is there the numbness, weakness, or hand clumsiness. That means the 5 movements patient can't do. That is what is called the motor movements. 5 movements the patient will be unable to do. That is called the hand clumsiness. So also the gait disturbance also we have to think for. Sometimes in cervical myelopathy, wide stepping gait we can observe in patients. The hand clumsiness or motor weakness in the hand or the finger flexion, grip strength weakness we can see in cervical myelopathy. So the weakness in herniated cervical disc, the muscle weakness we can observe. So also the numbness, pin and pin needle sensation also we can observe. So red flag signs are weight loss of the patient. It's a gradual weight loss of the patient. We have to think whether malignancy is there or not. We have to think and evaluate accordingly. So if there is any fever, sometimes in tuberculosis, evening rise of temperature we can observe. That means we have to look for any fever or not, or morning stiffness. So morning stiffness usually we are seeing in ankylosing spondylitis, where the morning stiffness the movements will reduce the pain in angular. That is the in the lower level also we can see early morning stiffness will be there. While the patient move or activities will reduces the pain. So these are the things we ought to keep in mind while taking the history. The first is pain. While analyzing the pain, the site of the pain, radiation of the pain, and aggravating factors of the pain and relieving factors of the pain. So also we have to ask any neurological deficits like there's a numbness, weakness, and clumsiness of hand and gait disturbance is there or not. So also the red flag signs also we have to keep in mind whether there is any gradual loss of weight loss, and if there is any evening rise of temperature or fever is there or morning stiffness is there. If morning stiffness is there, we can assume that there is an inflammatory ankylosing spondylitis like that. So after taking the history, we have to inspect the patient. That's Shannon. So in some cases, we can see that usually our vertebral column has the cervical lordosis, and thoracic kyphosis, and lumbar lordosis, and sacral kyphosis. Because of this curvature of the cervical spine is maintained by the curvature. So that means cervical lordosis is maintained by the cervical muscles and ligaments. Because of this pull of the cervical muscles and ligaments, a little bit roll of the intervertebral disc also. That's why the cervical curvature is maintained. Long-term working professionals like the IT fields, their head will be always this opposite posture. We have to maintain the cervical lordosis. That's why the older person saying that kindly avoid the pillow while laying down, so that the cervical lordosis and lumbar lordosis we can maintain. Avoid a cot like that. Soft cot also we will ask to avoid the patient in some case, whether the cervical lordosis and the lumbar lordosis is obliterated. If that much of muscle spasm into the cervical spine, the cervical lordosis will be reduced. The straightening of the cervical spine we can observe. At another clinical conditions also there where the cervical lordosis is reduced. That we will discuss later. So also the abnormal posture of the cervical spine. In some cases, we can observe that the head is shifting forward. That is, in IT professionals, always they will keep their head looking downwards. So also the executives always doing their work looking downwards. So also the dental surgeons, their head will always downwards like that. So also is there any deformity also we are there that we have to observe. Any muscle wasting, shoulder, hand, that also while looking the patient. So always keep a keen eye to the patient's posture and the muscle wasting and posture and the forward shifting of the head like that. Is there any swelling is there that also we can observe? A straightened spine may be due to this muscle spasm. So many conditions, if there is a paraspinal injury or a ligamentous injury where that much of paraspinal spasm, the straightened cervical spine we can see. So also the cervical spondylitis also we can see because of this muscle spasm, we can observe the straightening of the cervical spine. And hand muscle wasting we can see in cervical myelopathy, where the chronic nerve root compression, hand muscle wasting we can observe. So while doing the inspection, these are the things we have to keep in mind. So we have taken the history and inspection. Darshana, Prashana we have covered. Then we have to do the Sparshana. That means some special test we have to do in order to make a clinical diagnosis. So before treating a patient, we have to make a clinical assessment. For that, first we have to do Darshana, Sparshana, Prashana. That means inspection. Then comes Prashana. That means history taking, detailed history taking. Then comes the palpation. So first we have to put our thumb on the posterior aspect of the neck and gently move from the C1 to C7. Any midline tenderness is there or not, we can observe. So also the muscle spasm also we can feel. This midline tenderness we can usually see in disc, intervertebral disc prolapse. So also the infection at that level. So also the paraspinal spasm in spondylosis. The cervical spondylosis, we can observe the paraspinal spasm. This is a protective mechanism taken by our body. While the muscle becomes spasm, the neck movements will be restricted. So the paraspinal spasm we can see in cervical spondylosis. So also the step deformity or we can see in instability, fracture, dislocation like that. So while doing the palpation, all these things we have to keep in mind. Is there any tenderness, paraspinal spasm or step deformity? All these things you have to keep. After the palpation, we have to assess the range of movement of the cervical spine. Usually the cervical spine has 4 movements. Flexion means forward bending movement. So also extension, backward movement of the head, flexion, extension, and lateral rotation movement we have to assess. So also the lateral bending. So 4 movements we have to assess. Only 4 movements are there at the level of the cervical spine: flexion, extension, rotation, and lateral bending. Usually the extension of this cervical spine will be 80 degree. Extension will be 80 degree. So also the lateral rotation will be also 80 degree. So the flexion will be 50 and the lateral bending will be 50. So 50, 50, 80, 80. 52 values you have to keep in mind. 50, 50, 80, 80. Flexion, lateral bending, 80, 80. Extension 80 degree and lateral bending 80 degree, and flexion 50 degree and rotation 50 degree. 50, 50 and 80, 80. The range of the movement we have to look for. So the painful and restricted movements we can observe in spondylosis, and the severe restriction we can observe in advanced diseases. While observing the cervical movements, we have to keep all these things. And the painful restriction movement we can see in spondylosis, and severe restriction we can see in advanced diseases. So now we are doing, after taking the history, inspection and palpation and observing the range of movement, we have to do some clinical examinations. So we are the practitioners at that time. Only X-ray is available as an evaluation or the confirmation test. We can depend. Nowadays, CT and MRIs are available. At that time, first our clinical practice started with the history taking. All the clinical examination is very, very, very important. We have to make a clinical diagnosis. In order to confirm our clinical diagnosis, we have to go for the radiological examinations and lab examinations like that. So the clinical assessment is very, very important while considering the cervical spine examination. Special test for cervical IVDP or spondylosis with the root compression. The first and the foremost test widely doing is pulling test. It is a very simple test. Ask the patient to sit on a chair or stool and lateral flexion and extension of the extension and axial loading over the skull. You can see the picture. This is the posture. Ask the patient to sit on a table, stool, and lateral flexion and a little bit extension of the head. Lateral flexion. Sorry. Lateral flexion and a 30-degree extension of the head, and the axial loading is given to the occipital region. Axial loading is given to the occipital region. Lateral bending towards the affected side and extend the head to 30-degree, and the axial loading is given so that the patient experience the radiating from the pain, radiating from the pain from the neck to the upper lip. That if the test is positive, the pain will aggravate. That test is Spurling test. It is very, very, very simple clinical examination. Ask the patient is sit on a table and lateral bend to the affected side and a little bit extension up to 30 degrees extension of the head, and the axial loading is given to the head so that the patient experiences radiculate or radiating pain to the root which is being compressed by the cervical nerve root is affected or not, we can assess. The test is called a Spurling test. The second test for thoracic outlet, the same, it will mimic the cervical problem. We have to rule out this also, thoracic outlet syndrome. So that test is called the Adithya test. It's a vascular problem. Assess the compression of the subclavian artery by scalenus muscle or the first rib. Cervical rib also we can do this test. In cervical rib also the same thing, we can mimic the vascularity visibility, or is there any vascular problem, the numbness, tingling sensation, radiating pain. In order to rule out from this cervical spondylitis or cervical disc herniation or myelopathy, such conditions, we have to do this test also. That is what is called the thoracic outlet syndrome. Here, to assess the compression of the subclavian artery by the scalenus muscles or the first rib that will irritate or compress the cervical subclavian artery. The patient sit or stand with the arm on their side. Ask the patient, that is comfortable. Ask the patient to sit on a table and palpate the radial pulse on the affected side. If it is not affected, very well we can feel the radial pulse. Palpate the radial pulse on the affected side. Then turn the head towards the affected side. Ask the patient to turn the head towards the affected side and gently abduct the arm to 30 degree and do the external rotation. Ask the patient to take a deep breath and hold it. If decrease or disappearance of the radial pulse indicates the positive test. That is what is called the Adithya test. Ask the patient to sit on a table and ask him to turn his head towards the affected side and abduct the upper arm around 30 degree and do the external rotation, and ask the patient to take a deep breath and hold it for a while, and you observe the radial pulse. And if it is diminished, that means the test is positive. The test is called Adithya test. So two tests we have studied. First one is Spurling test. In Spurling test, we can assess which nerve root is affected. While doing this Adithya test, if the test is positive, while doing the test, the radiating pain will aggravate. While doing the Adithya test, it is to assess the vascularity of the subclavian artery. Ask the patient to sit on a stool and turn the head to the affected side and gently do the gently abduct the upper arm 30 degree and do the external rotation. Ask to do the external rotation. Ask the patient to take a deep breath, and if the radial pulse is diminished, that means the Adithya test is positive. Then comes the roots test. So ask the patient to abduct and external rotate the shoulder 90 degree and the elbow flex. Ask the patient to abduct the shoulder in 90 degree. Ask the patient to do the abduction of the shoulder joint 90 degree and flex the elbow also 90 degree. So the shoulder and the elbow will be at the 90 degree, and ask the patient to repeatedly clench and open the fist for 3 times. Ask the patient to extend and flex the fingers for 90 degree. Keep the shoulder in 90 degree, elbow in 90 degree, and ask the patient to flex and extend the fingers of the hands for 3 to 5 times. If disappearance of neurological and vascular symptoms or disappearance of the radial pulse are highly suggestive for TOS test. So the roots test and the Adson test is to differentiate the vascular problem is there or not. The first one is the Adson test, and the second one is the roots test. So we can make a differential diagnosis of Raynaud's syndrome with the cervical problem, which is usually bilateral with the vascular changes in the hand. By doing a simple test, roots test, we can assess whether the Raynaud's syndrome is there or not. So the next test is to rule out and assess the cervical myelopathy in chronic cervical spondylosis or any other pathology causing the spinal cord. At first, I had said that the cervical lesions are divided into 2: cord lesion and column lesion. Cord lesion means diseases affecting the vertebrae and the intervertebral disc, like that. And the column lesion means the diseases affecting the spinal cord. Here, the chronic cervical spondylosis or any other pathology causing the spinal cord compression, resulting in clumsiness of the hand and gait disturbance we can see, and the wasting of the intrinsic muscles. The chronic cervical spondylosis or any other pathology causing the spinal cord. In chronic, so also the cervical canal stenosis will lead to cervical myelopathy. That means affecting the diseases affecting the spinal cord. The chronic cervical spondylosis or any other pathology causing the spinal cord compression, resulting in fine movements will be affected. Clumsiness of the hand and wide stepping gait we can observe, and so also the upper limb and lower limb stiff lesions we can see, weakness we can see. That is the classical signs of the myelopathy. To roll out this one, the simple test we are doing is Hoffman test. Hold the patient's middle finger at the distal phalanx, tip of the finger. So this is the Hoffman test. Hoffman test. Hold the patient's middle finger at the distal phalanx. Flick the nail or tip of the middle finger downwards, causing quick flexion and relation of the finger. Your thumb and index finger involuntarily flex or twist in response to this flick. That means hyper-excitability of the verticospinal tract. So how we are doing this Hoffman test? The patient to sit on a table, hold the distal phalanx of the middle finger, a sudden 2 to 3 flickering into the distal phalanx. At that time, we can see that abnormal movement of the index and the thumb. That means the Hoffman test is positive because of the hyperexcitability of the verticospinal tract of the spinal cord, which is usually seen in cervical myelopathy. The first test we have done is Splint test. Second one we have done is Adson test, roll out the vascularity. Then Roots test also we have done to roll out any vascular deficit, Raynaud's disease, like that. The fourth one we have done is the Hoffman test, where holding the distal phalanx of the middle finger and flickering the middle finger, involuntary movement of the index and the thumb finger we can observe. That is just because of the hyperexcitability of the corticospinal tract. The last test which you are doing is not last. Hermiter's sign. Hermiter's sign is also a very simple test. If the test is positive, we can make a clinical diagnosis of the cervical myelopathy. While the patient is standing or sitting, the neck is hyperflexed. That means ask the patient to bend the head forward, hyperflexed, resulting in a shock leg. While we are sitting in a barber's chair, we will flex the neck downwards. That is what is called the barber's chair phenomenon. While the patient standing or sitting, the neck is hyperflexed, resulting in a shock-like sensation radiating down the entire spine up to the extremities. While the patient standing or sitting, the neck is hyperflexed, resulting in a shock-like sensation radiating down the entire spine up to the extremities. The test is called Hermiter's sign. So this is the Sperling test. This is the Hermiter's sign. If the myelopathy is present, the patient gait will be like the wide-based gait we can observe. And in myelopathy, we can the Hoffman signs will be positive. After completing this test, that is history taking, inspection, and palpation, and special test, we have to look for the neurological examination also, the higher function of mental functions like orientation, paint, and place, and like that. And whether the patient is conscious or not, higher functions we have to look for. So also we have to test all the cranial nerves. So which while considering the cranial nerves, the axial nerve, 12th nerve is responsible for shoulder surging movement. That we have to look for when axial nerve is involved or not. That means cranial nerve involvement also we have to look. So also gait of the patient in cervical myelopathy, wide stepping gait we can observe. So also the sensory and motor status of the patient also we have to look for. So also the reflexes, deep tendon reflexes we have to look for. So any abnormal reflexes is there that also we have to look for, and the bladder and bowel signs that we have to look. It is very important. Bladder and bowel signs are whether the bladder or bowel is functioning normally or not. So after having a clinical evaluation, neurological examination, motor weakness means no root compression is there. If it is a myelopathy or spondyloitis, if there is any no root compression, the weakness of the muscles we can observe. The sensory loss also we have to look for, and the reflexes. If the reflexes are diminished, that means the root lesion is there, and if the reflexes are increased, cord compression is there. That is the difference. If the spinal cord is compressed, then just like that of upper motor neuron lesion, all the deep tendon reflexes will be exaggerated. If the reflexes is being diminished, that means the nerve root is just like that of a low motor neuron lesion. The root deep tendon reflexes will be diminished. So also if there is upper motor neuron lesion is there, then the Hoffman sign, which we have studied later, just before Hoffman sign will be present in myelopathy like that. That upper motor neuron lesion like symptoms the patient we can see. So also the Babinski sign also observed in upper motor neuron lesion. That is the neurological examination also, the cranial nerve examination. So also the neurological examination also we have to look for. The yet another test is called the neck distraction test. Neck distraction test. While the patient lying down on the cot, a gentle traction is given to the neck. If the pain subsides, that means the root compression is there. Now root compression is there. That test is called neck distraction test. While the patient is lying on a table, gentle traction to the cervical region, and that will relieve the pain to the upper limb. Then the test is positive. The test is called neck distraction test. Then another test is called the shoulder abduction test. If the patient is having the herniated disc with a root compression, while the hands, while the upper arm laying on the neutral position, patient experiences excruciating pain. While ask the patient to keep the hands on the head, the pain relieves. That test is called shoulder abduction test. If the pain relieves while keeping the hand over the head, that means the shoulder abduction test is positive. Usually, we are seeing in nerve root compression of the herniated disc or the osteophytes irritation of the nerve roots like that. So a clinical evaluation we have done. We have make a clinical diagnosis. After having the clinical evaluation, we have to look for the radiological examination or X-ray like that, not to confirm our diagnosis. The conditions-wise diagnosis and finding each and every one of the diseases which are affecting in the cervical region mainly are cervical disc disease or cervical spondylitis and the myelopathy. So we are discussing each conditions like that, condition-wise diagnosis and findings. The cervical first one is cervical spondylosis. The findings are in cervical, usually the patient present with chronic neck pain, reduced range of movement. Possible radiculopathy will be there. If the nerve root irritation is there, there will be radiculopathy from the neck to the upper limb. So after having the clinical evaluation, we will ask the patient to take an X-ray. What are the things we can see in the X-ray is osteophytes. Osteophyte means we have 7 cervical vertebrae at the level of the 7 cervical vertebrae at the level of the cervical spine. So the first and second vertebrae, there will not be any disc, atlas and axis. And second and third, you can see a space. This is the intervertebral disc. The normal space will be like this. Here also the normal space. Here also somewhat normal space. Here the disc space is being reduced because of the degeneration of the intervertebral disc. What happens there? While the intervertebral disc get degenerated, that will affect the stability of the whole spine. So if the disc degenerated at the level of C5 and C6 or C6, C7, so that will affect the stability of the whole spine. In order to compensate the instability, the new bone formations will be formed in and around the cervical spine, and that will irritate at the level of the intervertebral joints. That is called the osteophytes. And if the osteophytes irritate the soft tissues, that the muscles and ligaments in and around the cervical spine, that will lead to the cervical muscle stiffness. So if you irritate the nerve roots, you can observe the radiculopathy. So while taking the X-ray, usually we will see in cervical spondylitis, here it is straightening of the cervical spine. So all the osteophytes you can see, also the disc space narrowing. So we can diagnose the spondylosis as the Griva Sandigadavada. Shogham Sandigade Anilaga, Prasarana Agunjana Yoga, Pravartincha Savedana. So we can conclude, we can come to diagnosis of the cervical spondylosis as the Sandigadavada or Griva Kasherika Chakra Valaya Vigrati, where the degeneration of the cervical spine, degeneration is there. That we can say it's Griva Kasherika Chakra Valaya Vigrati. So what is the treatment of the cervical spondylosis? Cervical spondylosis. First, of course, we have to give inflammation will be there. In order to reduce the inflammation, we have to give Dibana Pajana, Amma Pajana, Aushadas like Amrudotran Kashayam, Shaddaranam Guliga, like that. First, Kashaya Pana, Acharya very well saying that Kashaya Pana Patyane. In order to reduce the inflammation or ama, we have to give the internal medicines in order to reduce. First line of the treatment is give maximum rest to this area and give internal medicines to reduce the inflammation so that the pain will comes down. So internal medicines to reduce the pain and inflammation. In Ayurvedic concept, we can say that it is to reduce the ama at that area or inflammation at that area. Kashaya, very well in Juridical Acharya says that Kashaya Pana Pathyane Dashaha Idilengide Sarpirdadyala. After 7 to 10 days, we can give Sneha preparations. After that, we can give Snehana preparation. It is a Vada Vyadi, Sandigata Vada. We can treat accordingly. So next line of the treatment is giving the Snehaban. 2 ways we can give
Achabana and Vicharana. Achabana means we are giving the medicated ghee in a particular dose and gradually raising the dose according considering the considering the Agnibala. Pure ghee we are giving raising the dose 20, 30 or 25, 50 like that. Achabana or Vicharana. Vicharana we can give either with some kanji or some along with some light food, legu ahara, along with the food we can give Vicharana for 7 days. After attaining the Sammik Snigdha what we are doing is Svedana Chikitsa. Along with these internal medicines, next at that time, after the Snegapana, we will consider we have to treat the Vadavya. For that condition, usually we are giving Maharasana the Kachaya, along with this Laksha Gulgulu, Yogaraja Gulgulu, according to the condition of the patient. According to dosha prakriti or the condition of the patient, we can select the medicine. Maharasana, Rasana, Randadi, Rasana, Saptaka, like that we can give. So also neuroprotective medicines like Prasarani, the Kachaya. And very well, and the second phase, we can start this Cervilon or Cervilon capsule also 2BD. After completing the Snehabana, the internal medicines we are giving, along with that, we will start the Swedana Prakriya. Snega, Sweda is the treatment principle. After the Snegapana, Swedana treatment, we can see the Ushma Sweda like that, local heat, or Pidichil, Kiri, and all these things we can do at that time. After that, we will do the Shodhana Chikitsa also, in order to eliminating the disease causating factors from our body. That means Shodhana Chikitsa we are giving using Vasti according to the Yoga Vasti or Shveta Vasti or according to the condition of the patient. Along with the Swedana treatment, we can start the Griva Vasti also. In such condition, Griva Vasti also will give that will strengthen the muscles and ligaments in and around the cervical spine. After the Shodhana, along with that, this Swedana Prakriya, we'll start the Marma stimulation. Usually, what I am doing is, I will stimulate the Krikadiga Marma. Shira Griva Yoga Sandhane, Krikadiga Nama, Tatra Ajala Murtada. We'll give the Marma Chikilsa, Krikadiga, and also the Marma to the Marma Chikilsa, to the Neela and Manya Marma. So also the Amsa Marma, Bahu Murdan Griva Mathi Amsa Vedaskando, Amso Nama. Tascha Bahu Swabashosho. Very beautifully in Marma Pragarana it is said. So also Prashto with Prashtavamsa, Amsa Balago Nama, Tascha Bahu Swabashosho. So we have to concentrate the Amsa Marma and Amsa Balaga Marma, Brigadi Marma also. So also in some cases we will give treatment to the Parshusandi Marma. So Krikadiga, Neela, Manya, Amsa, Amsa Balaga, and Brigadi, we have to keep in our mind. After the Shodhana Chikitsa, Rasayana Aushadhas we are giving in order to nourish the tissues in and around. We are not to reduce the Saptadhatu. We are not to nourish the Saptadhatus, Rasayanas. That is the principal treatment protocol what we are following. So, cervical spondylitis. What is cervical spondylitis? It's a degenerative arthrosis of the cervical spondylosis. It's a degenerative arthrosis of the posterior intervertebral joints and the degeneration of the intervertebral disc, along with the osteophyte formation, that will irritating the nerve roots in and around the cervical spine. That will lead to the spasm and inflammation into the cervical region. So the line of the treatment is to first reduce the inflammation. Second, we have to strengthen the muscle. We have to strengthen the muscles and ligaments in and around the cervical spine. Then we have to increase the range of movement. For that purpose, we are giving Swedana Kriyas. Along with that, this Marma Chikitsa we are giving. Grivavasti also will give better, very good result. The internal neuroprotective medicines also giving the Cervilon and Prasarani Adi Kachaya and the Vadahara Aushadas like Maharasana, the Yogaraja Gulguli we can give internally. So after the symptoms have subsided and the range of movement has improved, we'll ask to do some cervical exercises also, isotonic exercise and isometric exercises. Isotonic means without resistance, ask the patient to do the flexion, extension, lateral bending, and lateral rotation movements without any resistance. All movements with resistance using our hand. that is called isometric exercise that will strengthen the muscles in and around the cervical spine. Later on, we'll start a rasayana in order to nourish the saptadhatu so that we can prevent the disease further damage, further degeneration at the level of the cervical spine. The second condition usually we have met is cervical disc prolapse. So, what is invertebral disc? Invertebral disc is a tough fibrous tissue externally. Internally, there is a jelly-like material called nucleus pulposus. The external tough fibrous material is called the annulus fibrosus. Because of the repeated strain or the age-related changes, the invertebral disc will become weak. Because of the repeated strain or age-related changes, sometimes the microscopic injuries will be formed in and around the invertebral disc. So, our cervical spine is covered laterally and anteriorly by the paraspinal muscles and ligaments. Posteriorly, there is no such support. So, usually the disc herniation will be the posterior lateral. Posterior laterally. The disc is composed of external material called tough fibrous tissue called annulus fibrosus. Inside that, there is a jelly-like material called nucleus pulposus. Because of this repeated strain, the annulus fibrosus, at the level of the annulus fibrosus, microscopic injuries will form or become the age-related changes. The annulus fibrosus will be structurally unsound. A added strain may herniate the nucleus pulposus out from the confines of the annulus and compress the one of the nerve roots which is emerging through that area, will produce radiculopathy or sensory problems at the level of its dermat. So also the invertebral disc prolapse can occur at any level in our spine, namely cervical, thoracic, and lumbar. But usually it met with the cervical region and the lumbar region. Why? This is the most mobile area of our spine, cervical region and lumbar spine. In case of this thoracic level, because of the support of the rib cage, the disc is being well protected. At the level of sacrum, it is situated inside the pelvic bone. So the mobility is being very less. The more mobile area is cervical and lumbar. Usually at the cervical level, it is affecting C4, C5, C5, C6, and C6, C7. But at the level of lumbar spine, it is affecting L4, L5, and the L5, S1 level. So the contour of the cervical spine, you can observe the cervical level, there is a cervical lordosis, and thoracic level, there is a thoracic kyphosis, and lumbar level, there is a lumbar lordosis, and at the sacral level, there is a sacral kyphosis. So the cervical lordosis is maintained by the pull of the muscles and the ligaments in and around the cervical spine, while the contour of the thoracic level is by the bony architect of the spine. Bony architect, the special alignment of the bones like that. At the level of lumbar level, lumbar lordosis is mainly due to the shape of the intervertebral disc at the level of the lumbar spine. So usually we are finding in cervical disc disease, cervical disc prolapse, the findings are radiating pain to the arm. Radiating pain to the arm. While doing after having the history, inspection, all those things, we have to go according to the scientific way. You have to do the Spurling test. If it is positive, we can suggest that the intervertebral disc prolapse is there. How we'll do this Spurling test? Ask the patient to sit on a table, turn the head to affected side, and extend the neck to 30 degrees, and the axial loading is given so that the patient experiences pain to that affected area. The diagnosis is confirmed by the MRI. Intervertebral disc prolapse, you never expect to get it in the X-ray. Only soft tissue images we can depend on the MRI. The gold standard investigation is MRI, where you get the axial view, coronal view, and the sagittal view. Here you can see the disc is prolapsed and compressing the spinal cord also. So, what is the diagnosis of invertebrate disc? According to the Ayurvedic view, so vitiated Vada dosha, Tiktoshana Kashaya, Alparusha, Apramita Bhojanegi, Dharano, Dirana, Nisha Jagara, Aticha Bhashane, Kriya Adyoga, Fi, Shoga, Chinda, Vyayama Maidane, Grishmo, Ahoratri, Uttande, Pragupyadi Samira. So, the vitiated Vada dosha, after getting Sthana Samsraya at the invertebrate disc, after the dosha samorchana producing the disease. So, in brief, we can say it is a Vada Pragopa affecting the Giva Kasherika Chakravalaya. Griva Kasherika Chakravalaya Vigurdi. We can diagnose it as Griva Kasherika Chakravalaya Vigurdi. After coming to a clinical diagnosis and the radiological diagnosis, we can, what is the same treatment protocol we can give the internal medicine. Of course, while the disc get prolapse, there will be inflammation. At that time, usually what we are giving initially inevitable disc prolapse, internally at first we will give Shadharana Kashaya. Shadharana Kashaya in order to reduce the inflammation there, or you can select the Rasana Saptaka Kashaya. Along with that Shadharana Guliga, you can give Simhanada Guliga is there. After subsiding the inflammation, while the inflammation gets subsided, the patient experiences pain relief also. After subsiding the, after giving the internal medicines, after 7 to 10 days, we'll start Snehapana according to the condition of the patient. Here we are selecting the disease, Snehana is Indagandhakrita. Usually in invertebrate disc prolapse, we are giving Indagandhakrita. And content is Dashamula. It's a very good Vata pacifying agent. So also for the Srodha, if there is any Srodha Rodata, it contains Shatpala also. Pipili, Mula, Chavya Chitraganagarehi. So, Indagandhakrita is usually we are selecting according to the patient's Vada Prakriti. At another medicines also we can then according to the age and the condition of the patient, we can select the Grida for Snehapana. We usually at that time we will ask the patient to wear the cervical collar also. In invertebral disc prolapse, we have do the cervical spine manipulation also that will give immediate pain relief. Cervical spine manipulation also we do. After this Snehapana, the Svedana Kriyas like Ushma Sveda, Pidichil, Kidi, like that we can start. Along with that, Griva Vasti also we can start. After the Kidi, we can give the Yoga Vasti according to the condition of the patient in order to specify the Vata. Throughout this period also, after the pain reduced, we will start the Marma stimulation also. The Krigadika Marma, Nila and Manya, Amsa, Velaga. Marmas are also stimulated in order to strengthen the muscles. Marmanama, Mamsa, Sira, Snayu, Asti, Sandhi, Sannipatidava. Teshu Subhavadi Eva Prana Tishtati. So the obstruction of this prana, we have to give the prana stimulation. So Marma stimulation also that will give very good result. And Marmaticals also will do. After that, we'll give the Rasayanas for nourishing the tissues, Saptadhatus. That will give immense strength to the invertebral disc also. The second condition is called invertebral disc prolapse. Usually, the herniation of the invertebral disc we can observe at 4 levels. Sometimes it may herniate to the invertebral foramen. At that time, if the prolapse is, if the herniation into the invertebral foramen, the patient experiences sensory loss. If the herniation is towards the invertebral foramen. If the herniation is posterior lateral, herniation, there will be motor deficit will be, we can observe. Motor deficit we will observe. And if the prolapse is the central prolapse, that may lead to cervical myelopathy. So the prolapse can be divided into three levels. At the level of the invertebral foramen, so that the patient experiences sensory deficit. If the prolapse is towards the root, then the patient experiences the motor deficit. In case of cervical spine, if the prolapse is at the level of C4, C5, at that time, the C5 nerve root is affected, so that the shoulder abduction weakness we can observe. If the prolapse is at the level of C5, C6, that means C6 nerve root is affected. At that time, the patient experiences the biceps weakness. And if the prolapse is at the level of C6, C7, that means affecting the C nerve root, the triceps weakness the patient experiences. And if the prolapse is at the level of C7 and T1, C7 and T1, that means affecting the C8 nerve root. At that, the finger grip strength will lose to the patient. That are the motor deficit we can observe. If the prolapse is at the level of C4, C5 and affecting the C5 nerve root, shoulder weakness, shoulder abduction weakness patient observe. And if the prolapse is at the level of C5 and C6, that means affecting to the C6 nerve root, that means weakness of the biceps muscle weakness patient observe. And if the prolapse is at the level of C7, that means at that time patient experiences the triceps weakness. And the prolapse is at the level of C7 and T1. The patient experiences weakness, grip strength weakness patient experience. So also patient can't abduct the thumb. So in this MRA, we can see the central protrusion. That means the intervertebral disc is centrally prolapsed and compressing the spinal cord. Here you can see the posterior lateral herniation and compressing the nerve roots. Posterior lateral herniation and compressing the nerve roots. This is the axial view of the normal intervertebral disc. This is the spinal cord, and this is the spinal nerves, which is passing through the intervertebral foramen. Then comes the cervical myelopathy. In cervical myelopathy, the patient experiences gradual pain and stiffness to the cervical region. The patient observes experience a gradual pain and stiffness and restricted movement to the cervical spine. And sometimes it may worsen suddenly as a radiculopathy. Gradual onset with sudden worsening of the radiculopathy. Usually in cervical myelopathy, patient gait disturbance we can observe. So wide gating step, the patient usually walk with wide gating steps. So also hand clumsiness is there. The fine movements of the fingers will be lost. The patient can't do the button and can't hold the coffee mugs and can't write properly. Hand clumsiness can be seen. So the positive upper motor neuron signs we can see. Positive upper motor neuron signs. So here the upper limbs and the lower limbs are affected. Upper limbs and the lower limb stiffness we can see. Muscle spasm will be there. The muscle weakness is also there. The positive upper motor neuron signs we can observe. So if there is radiculopathy, it is affecting both upper limbs. But in herniation, we can observe only one side. But in myelopathy, it is affecting bilaterally. The diagnosis is confirmed by MRI. So this condition we can diagnose as Asti Snayu, that Vada, vitiated Vada affecting the Asti, Snayu, and the Sushupna Nadi also affecting. Sushupna Nadi also affecting. So also in this condition also we are giving internal medicine. Brahmana Kashayas are very good in such condition. Usually what I am giving is Dhanundara Kashaya and Prasaranadi Kashaya, along with that Dhanundara Gulia and this Kanjanara Gulia, if there is any spara like that. Initially we will get, so also Trayodashanga Guliga according to the condition of the patient. Initially we are giving Dhanundaran Kashaya, along with that this Cervilon capsule or Maharaja Prasarani Adikashaya, like that. After specifying the AMA, we will give internal medicines like Dhanundaran Kashaya and Prasarani Adikashaya and Trayodashanga Gulgulu and Kanjanari Gulgulu if needed cases. And so also the Avartana Thailas we are giving. So also the Cervilon capsule and Maharaja Prasarani, neuroprotective medicines we can give. And Snehavana, in such condition, myelopathy, first we are giving is Gulgulik Sandhyasti Majjagatam Vida. Gulgulik we are giving in Snehavana. After that, light Swedana we are doing, along with that, the massage to the both upper limbs and lower limbs, and Marma stimulation treatment all over the body we are giving. Not 7 Marmas are also stimulated in such condition. So also the Shodhana Chikitsas like Shashtika Pindasada is very effective according to the condition of the patient. And Marma therapy, along whole Marma stimulation we are doing. After that, we will give the Rasayana Chikitsa. Here you can see the cord delamination here in myelopathy. Here it is. The disc also degenerated and the spinal cord is also degenerated here. So also the other condition affecting the cervical region is rheumatoid arthritis, where you can observe the neck pain plus stiffness, atlantoaxial instability we can see. Radiologically, we have to look for RI factor, and MRI also we are taking. And the Ayurvedic view, we can take this as an Amavada. The same protocol we can give according in the internal medicines according to the condition of the patient. So ankylosing spondylitis is another condition which is affecting. Usually the morning stiffness patient experiences conditions and reduced spinal mobility. That is very important. Reduced spinal mobility, the reduced spinal movement. So in ankylosing spondylitis, movement reduces the pain, but the patient experiences pain at night because at that time the patient is taking rest. So movement reduces the pain. X-ray, you can observe the bamboo spine. Bamboo spine, we can see. So this such condition, we can say as is a Vada disorder. Prashtavamsha Sandhigada Vada Vigara. We can say it as Prashtavamsha Sandhigada Vigara. The treatment, same protocol as for the Vada Vigara we can give. Then tuberculosis. Here you can see the neck pain, evening rise of temperature, and a neurological deficit, later onset of neurology. Here you can see the soft tissue swelling here in the MRI. It is a tuberculosis spine, compressing the spinal cord. So increased ESR will be there, increased lymphocyte count will be there in tuberculosis spine. Ayurveda, we can say is Astis Nayugadavada and Rajeshma Vigara. So the treatment protocols, we have to give supporting Ayurvedic medicines, Rasayana medicines, along with that the modern medicine also. Then comes the tumors of the spine. Severe in tumors of the spine, severe pain at night we can observe. So also progressive neurological deficit also in Shavanama conditions. Progressive neurological deficit we can observe. The diagnosis confirmed by the MRI or the biopsy. And the treatment is supporting treatment only. So in spondylosis, chronic pain will be there. X-ray we can take, and we can consider it as Sandhigadavada. And disc prolapse, the radiating pain you can observe, only one arm. And the MRI, we can say it as a Vada disorder. In myelopathy, upper motor neuron lesions, we can see. Upper limbs and lower limbs affected. Bilateral radiculopathy, we can see. RA, we can say it as a Sandhigadavada of the intervertebral joints, and tuberculosis and tumor. These are the conditions mainly affecting the cervical spine. If there is radiculopathy, think about the disc, and bilateral radiculopathy, think about the myelopathy. Night pain plus the weight loss, we have to think about the tumor and tuberculosis, and always correlate clinically and radiologically. Now we are come to the clinical case presentation. 3 cases we can discuss. 64-year-old male farmer came from Kottayam, presented with complaints of neck pain and stiffness of gradual onset and progressive course. He reported clumsiness of both hands. That means fine movements being affected, particularly difficulty in buttoning his shirt and writing, indicating impaired fine motor skills. Over the time, he developed a weakness involving both upper and lower limbs. Upper and lower limbs weakness he developed, along with unsteadiness while walking. He also complained of numbness in his hands and feet. On further inquiry, he had symptoms suggestive of autonomic involvement, like including urine urgency, hesitancy, and occasional incontinence. I shall repeat it once. A 64-year-old male farmer from Kottayam presented with complaints of neck and stiffness of gradual onset and progressive course. Not sudden onset, gradual onset. He reported clumsiness of both hands, particularly difficulty in buttoning his shirt and writing, indicating impaired fine motor skills. Over the time, he developed weakness involving both upper limb and lower limbs, along with unsteadiness while walking. He also complained of numbness in his hands and feet. On further inquiry, he had symptoms suggestive of autonomic involvement, including urinary urgency, hesitancy, and occasional incontinence. So on general examination, the patient is conscious, oriented, and cooperative. Poster, loss of cervical lordosis with neck stiffness. Loss of cervical lordosis with neck stiffness, muscle wasting noted in the intrinsic muscles of the hand. No obvious deformity of deformity or skin changes. So on motor examination, muscle bulk, wasting of intrinsic muscles of the hand muscles, the muscle tone increased in both upper limb and lower limb, upper motor neuron lesion, and the spasticity is upper motor neuron lesion like pattern. Increased tone both upper and lower limbs, and the spasticity is there, both upper limb and lower limb. Power, muscle power. While examining the muscle power, weakness of the upper limbs, distal muscle power is weakened compared to the proximal. So also weakness of the upper limb. So the upper limbs are more weak compared to the lower limbs. The coordination. While we examine the coordination movement, the impaired fine motor movements of the hand. So while examining the motor system, muscle bulk, while examining the muscle bulk, wasting of intrinsic muscles of the bilateral hands, the muscle tone increased in both upper limb and lower limb. That is also the spasticity is there. The muscle power, weakness in the upper limbs, weakness in the lower limbs. Upper limb weakness is more compared to the lower limbs. Coordination, impaired fine motor movements of the hands. By examining the reflexes, the deep tendon reflexor, biceps reflex exaggerated, triceps reflex exaggerated, knee hyperreflexia, that means exaggerated knee jerk, and the ankle jerk is also exaggerated. Superficial reflexes like plantar reflexes, positive Babinski's sign. Hoffman's sign is also positive. Hoffman's sign is also positive. Other examinations like sensory examination, loss of vibration sense, impaired joint position sense, that proprioception is impaired, diminished sensation of light touch, pain, and temperature. While examining the gait, the spastic with the wide-based gait, loss of balance, and difficulty in turning. See, finger escape test sign is positive, grip and release test is impaired, Hermiter's sign is positive. Hermiter's sign is positive and Spurling test is positive. Very important. Hermiter's sign is positive and Spurling test is positive. Grip and release test, that means impaired grip strength. And autonomic system examination, by look for urinary urgency is there, hesitancy is there, occasional incontinence is there. So while taken the MRA, it is mainly affected at the C4, C5 and C5, C6 and C6, C7 level, where the lumbar cervical canal stenosis is also observed. So imaging findings explain the patient's upper motor signs, that means cord compression, hand dysfunction, cervical cord plus anterior horn involvement, sensory loss, posterior colon development is there, involvement is there, gait disturbance, and autonomic symptoms also there, long tract involvement. So This case is a diagnostic case of cervical spondylitic myelopathy. That means the lesion affecting the cervical spinal cord. The symptoms and the hermitage sign is positive. That is very important considering this this myelopathy case. They have very simple test. Hermitage asks the patient to sit on a table and ask him to bend the neck forward. So the patient experience electric shock like pain. Here also because of the nerve roots are involved, the Hermitage sign is positive. So this is it's also lumbar canal stenosis compressing the spinal cord. So apomotor neural lesions we are observed. Both upper limb and lower limbs are affected. Hoffman sign is positive. That is also confirmative for this, considering this myelopathy. And radiological findings also in favor of myelopathy. So this case I treated initial phase considering the Amabhajana. First line of the treatment focused with the specification of the Amabhajana. Along with that, Lengana Bhajana therapy was administered for 7 days. In this case, I have given, first I have given Shadharana Kashaya, 15 grams of Shadharana boiled in water and divided into 1.5 cup of water and given for 7 days. Along with that, only Shadharana Kashaya and immobilized for 7 days. After the Amapachana, I have started the medicine with started Sneghabana using this Gulgulidikta Grada for 7 days. At first started with the Indaganda Grada for 7 days. Later on changed to Gulgulidikta Grada. And each administered for 7 days. Total 14 days Sneghabana was done. This phase aimed at the internal oleation and preparation for further therapies. So after this Sneghabana, external therapies like a light spinal massage was initiated. Marma stimulation therapy was performed at the level of Griva, Urogasheriga, and Kadiprasheriga. Marma stimulation treatment also has done. After that, we have started Dhanyamla Dhara for 7 days, combined with the gentle whole body massage in order to increase the muscle power, helped in reducing stiffness and improving the circulation. After the Dhanyamla Dhara, at that time, after completing this 14 days internal medicines, the internal medicines has changed to Dhanvantara Kashaya and Prasarinayadi Kashaya, Trayodeshanga Guliga, Cervilon capsule. Along that, Vijarana Sneghavana continued. Shashtika Pindasada done for 7 days following Dhanyamla Dhara, aimed at muscle strengthening and nourishment. Along with the Sarvanga Abhyanga. Along with this Shashtika Pindaseda, whole body massage also done with the Marma stimulation treatment. After that, the Shashtika Pindaseda done Yoga Vasti for 8 days. Played a key role in balancing Vada, improving in neurological fields. After that, finally, we have done the Shirodhara also. Later phase contributed to relaxation and neurological stabilization. So these are the internal medicines: Asana Sapta Kashaya, Simhanada Guliga, Dhanvantara Kashaya, Prasaranayadi Kashaya, Cervilon, Trayodeshanga Gulgulu, Cervilon tablet. These were continued for remaining course of the treatment. The clinical outcome and follow-up, I observed that progressive improvement in muscle power were observed and with each stage of therapy. Each stage of therapy, I observed the progressive improvement in muscle power. So also Sneghabana, the patient regained the urinary control. That is a very good result. And a gradual improvement in gait. Initially, patient needed support. Later, you will be able to walk independently. After completion of the treatment, 3 months, regular follow-up and physiotherapy exercise, the patient was able to walk without any support. Significant improvement in all presenting complaint. The patient continues on follow-up and is currently independently and performing daily activities. The patient is still under follow-up. Another case, a 60 2-year-old man, male from Trivandrum, presented with quadriparalysis due to RTA, road traffic accident, first treated in 2 private hospitals, diagnosed as fracture C4, C5, and C6. With post-traumatic axonal myelopathy, with atlantoaxial instability, patient catheterized, bowel control present. History of type 2 diabetes mellitus, history of lumbar disc degenerative disease also there. Assisted gait, the muscle power, right grade 3 and left grade 4. Reflex sluggish right upper limb and lower, sluggish right upper limb and lower limb. Superficial reflexes also sluggish. MRA shows the cervical asymmetry to right side, cervical canal stenosis C4 to C6 level, cervical canal stenosis at the level of C4 to C6, posterior center disc bulge at C3, C4, C4, C5 level, compressing the cord, minimal retrolithosis at L4, L5 level. The diagnosis, compressive myelopathy at the level of C4, C5, and C5, C6 level. So what I have in short, what treatment I have given is internal medicines, according Jasna Saptaga and Simhanada Gurgulu, and Marma massage also he underwent. Snehabana also done with the Indaganda Grada, Abhingam with the Oshma Svedam, Matravasti also done for 7 days, Shashtika Pindaseda for 7 days, Shirabasti has done for 7 days, and Shiradara for 7 days. So at the time of the discharge, the patient was able to improve his symptoms step by step, and he was able to move without any support. So it'll be a case. So 28-year-old IT professional complains of weakness and wasting of bilateral upper limb, first noticed in 2014. Treated in Sri Chitra. It is a rare case. Treated at Sri Chitra Institute of Medical Science. Later treated at CMC Vellore and was diagnosed as Hiramaya disease. Hiramaya disease at the level of the cervical spine. It's a very rare case. A 28-year-old IT professional complains of, still he is under my follow-up, professional complaints of weakness and wasting of bilateral upper limb. First noticed in 2014, treated in Sri Chitra, the prestigious institute in Trivandrum or the India, and later treated at CMC Vellore and was diagnosed as Hirayama disease, where the dura mater is engorging towards the spinal canal and compressing the spinal cord and producing symptoms just like that of the myelopathy. MRI revealed the thinning of the spinal cord at C4, C5 to C6, C7. MRI revealed thinning of the spinal cord C4, C5 to C6, C7. Internal medicines we are given. In this case, Dhannudaran Kashaya and Ashtavarga Kashaya has given internally. Snehabana with Indaganda Grida. 14 days Snehabana he has underwent, along with the Shirabala Nutan Avarti has given, and Shundi Baladi, Shirabaga Kashaya with the Kavikas Chorna we have given. Shundi Bala Kasha, Shirabaga with the Kavikas Chorna, Matravasti with the Indaganda Grada, he has underwent Matravasti with the Indaganda Grada itself, and Shiradara, Diguna Rasna we have used, and Marma massage given in between 10 days, and Shashtiga with the Ajamamsa, Shashtiga, Pindasedas done. The patient improved so much and he was able to do his work, and now he is happily doing his IT work. A 42-year-old village officer complains of severe neck pain and radiculopathy to left upper limb bone. Spinal movements were restricted and painful, deprived of sleep, visited private hospital, and conservative management tried for 2 months. There was no reduction of symptoms and was advised for surgical treatment. On examination, his gait is normal, no motor or sensory deficit, DTR was normal. The MRI shows that disc osteophyte complex at the level of C3, C4, C4, C5, and C6, C7 level. Disc osteophyte complex means the herniation of the intervertebral disc along with the osteophytes at that level. Because if the disc is get degenerated, that will affect the stability of the spine. And in order to compensate the instability, new bone formations will be formed in and around the vertebrae. Along with that, the disc herniation that will add on the symptoms. So this condition is called disc osteophyte complexion. Disc osteophyte is there. So also the disc cervical disc disease is also there. So here also I have given the internal medicine. First I have given Rasana Saptaka Kashaya with the Simkhanada Gulgulu for 7 days. After that, I have changed the medicine to Dhanvantara Kashayam with and Trayodashanga Guliga and Cervilon tablet. And along with that, Vijarana Snehapana, we have continued. Here he has underwent the spinal massage, Dhanyamla Dera, Matravasti, Grivavasti, Podikidi, and Yogavasti. After the completion of the treatment, his symptoms completely subside. Symptomatically, he was okay. So, lack of time. Coming to the first section, So these are the questions that we have to answer. A middle-aged man present with chronic neck pain aggravates on activity with the radiation of the trapezius scapula over the shoulder. That means only one side radiculopathy. Middle-aged man present with quick diagnosis you have to see while hearing. This is a case of cervical spondylosis. The second case, a 45-year-old man presents with neck pain radiating the outer aspect of the shoulder. Outer aspect of the shoulder, arm, forearm, and hand with a Sperling test positive. The outer aspect of the arm usually affects the nerve roots C6, C5, C6, and C7. The patient experiences pain on the outer aspect of the upper arm. If the patient experiences pain and the neurological symptoms on the inner aspect of the upper limb, that shows the nerve which is affected is C8. C8. Ulnar nerve distribution is impaired. This is cervical intervertebral disc prolapse. Here the presentation is on the outer aspect of the hand. So the involvement is at the level of C5, C5, C6, and C7. If the patient experiences pain on the inner aspect of the upper limb, that means that C8 nerve root is involved. A young girl presents with paresthesia on the ulnar side of the hand and forearm, increased local sweating, and absence or diminished radial pulse on Adson test. What is the diagnosis? TOS, thoracic outlet syndrome. Here we are doing the roots test. Roots test, as the patients sit on a stool, flex the shoulder joint 90 degree and the elbow 90 degree. Ask the patient to flex and extend the finger. The patient pulse diminishes. That means the test is positive. That is the roots test. Accent test. Ask the patient to bend the head on the affected side and 30-degree abduction of the hand and external rotation. Ask the patient to take the long breath and hold it for a while. If the radial pulsation diminishes, that means the vascular deficit is there. An older man presents with a chronic history of cervical spondylitis, associated with the progressive gait disturbance, that means wide stepping gait, and clumsiness in the hands, that means his fine movements of the hands being affected, and exaggerated deep tendon reflexes, that means biceps tendon reflex is exaggerated, triceps exaggerated, knee jerk exaggerated, ankle jerk is exaggerated in both upper and lower limbs. What is the diagnosis? That is the cervical spondylitic myelopathy. So here I am presenting on case and asking questions that we are to discuss. A 24-year, consider the age, a 64-year-old male patient present with a 2-year history of slowly worsening neck pain. That means gradual onset of neck pain that radiates down on the left arm into his left radial 3 fingers. Left radial 3 fingers. That means middle finger, index finger, and the thumb. He has no history of neck trauma. He originally saw his family physician who prescribed non-steroid anti-inflammatory drugs and physical therapy. His pain is improved with therapy but started to worsen again after stopping the medicine and physical therapy. He noticed recently that he is having difficulty in holding his coffee mug in his left hand. His fine movements were impaired. Physical examination shows weakness of the wrist extensor and decreased sensation over the left radial 3 fingers. His grip strength on the left side is also decreased compared to his right. What is most likely the diagnosis? Say cervical spondylosis, mildly affecting the spinal cord also, cervical spinal cord. What is cervical spondylosis? It is a second question. What is cervical spondylosis? It is a degenerative arthritis of the posterior intervertebral joints plus the degeneration of the intervertebral disc, and that will affect the stability of the vertebral column. And in order to compensate the instability, the new bone formations will be formed in and around the vertebrae, that is called the osteophytes, and the osteophytes irritate the nerve roots, producing the motor and sensory problems. What are the risk factors of the cervical spondylosis? Of course, because of the pain, old age persons will become sedentary in work. That may lead to metabolic diseases like hypertension, dyslipidemia, like that. What are the most common levels affected by the cervical spondylosis? Most commonly affected area is C4, C5, C5, C6, and C6, C7. How is the cervical spondylosis diagnosis? How we have to do the physical examination, clinical examination, test, and radiologically, and we have to confirm the diagnosis. What physical examination suggests a sluggish radiculopathy from the spondylitis changes? Usually, we have to do this pulling test, Hermitage test, and the Hoffman test, like that. The Hoffman test mainly differentiate the cervical myelopathy from the spherical spondylitis. What are the symptoms of the cervical spondylosis? Of course, the pain and restricted movements of the cervical spine with the radiculopathy to the upper limbs. Sometimes it is a gradual onset. Sometimes it will worsen suddenly. What radiological test performed for cervical spondylosis? Usually, we will ask the patient to take the X-ray AP, lateral and oblique, so that we can see the osteophytes, straightening of the cervical spine, and the intervertebral joint space being reduced. In order to confirm our diagnosis, we can send the patient for the MRI also. So we have how the cervical spondylosis is treated. We have well explained that one. So if it is not suspended, 95% of the patients will be responded with our conservative treatment and Ayurvedic treatment protocol, 95 to 96. But if the pain and the symptoms persisted long, more than 3 months, we will ask the patient to go for further evaluation. If needed cases, we will ask to do the surgery also. So here I am concluding my presentation.
Thank you, sir. Thank you for a very wonderful session. Thank you for your valuable time and for wonderful presentation, sir. On behalf of AVN Ayurveda, we would like to thank you for giving us a good lecture on this cervical masterclass series, sir. Thank you very much, sir. Thank you, sir.